We will chit chat afterwards.
Okay.
At the end.
Good evening, everyone. We welcome you all to OrthoTV online in association with Uttaranchal Orthopaedic Association meeting. To introduce today's topic and speaker, I hand over to our moderator, Dr. Ashok Sirohi.
Thank you, Dr. Neeraj Bijlani. Thank you, OrthoTV. Friends and seniors, greeting from Devbhoomi. First of all, let us pay homage to those who have lost their battle to Wuhan virus, including our own fraternity. Today evening, I am proud to present before you none other than our worthy IOA President, Dr. B.Shivashankar from Solapur, Maharashtra. Welcome, sir.
Thank you.
I would also like to introduce our President, Uttaranchal Orthopaedic Association, Dr. Singhal from Haridwar. Welcome, sir.
Thank you, sir.
I am pleased to introduce Dr. Puneet Agarwal from Haldwani, our dynamic honorary secretary of Uttaranchal Orthopaedic Association. Welcome, Dr. Puneet. We have with us Dr. Govind Sethi from United Kingdom as our distinguished panelist, and Dr. Hemanshu Kochhar from Dehradun, who is also our past secretary of Uttaranchal Orthopaedic Association, as our panelist. Welcome both of you, sir.
Thank you, sir.
Thank you. Thanks for having us. Thank you.
We welcome our chief coordinator from OrthoTV, Dr. Neeraj Bijlani from Maharashtra. Welcome, Dr. Neeraj.
Thank you, sir.
Now, I would request our president of Uttaranchal Orthopaedic Association, Dr. Singhal, for a welcome address. Dr. Singhal, please.
Thank you, Dr. Sethi. Thank you, Dr. Sethi, sir. And welcome and very good evening to all. I'm really thankful to Dr. Sirohi, who's moderating and has arranged all these things. And it's my privilege to join this session. This is the first session after me taking over as the president of Uttaranchal Orthopaedic Association. I'm very proud to be associated with Dr. Shivashankar. I mean, this is a very good feeling to have him here this evening. I welcome Dr. Sethi as our guest speaker, Dr. Shivashankar sir, our IOA president, Dr. Puneet, Dr. Hemanshu, and Dr. Sirohi sahab, Bijlani sahab, आप सबका बहुत-बहुत स्वागत है. और I'll request Dr. Sirohi sahab to please moderate the session.
Thank you, Dr. Singhal. Now, Dr. Shivashankar, I have known you for so many years, and yet when I meet you, I found a new Shiva every time. You have been a very inspiration for so many younger and not so younger orthopedic surgeons, sir. I am sure our audience could also be interested to know more about you. So I would have a brief interview from Dr. Shivashankar. Please tell us something about your childhood and graduation, sir.
Good evening. Thank you, Sirohi, for those kind words. Sometimes it's too much of appreciation also, because whether I am worthy of those appreciation, I'm not sure. So sometimes, as today in the morning, Rajshekaran, as past IOA president, has written in a message, few people who don't deserve much will get extra attention and they get more accolades. That is probably me. There are some people who get the just for whatever they have done. And there are many people like you, Sirohi, or Dr. Indra Mohan Singhal, or Puneet Agarwal, or so many people whom I can see on the screen. So they might be doing much more work than me or much more better work than me, but their recognition may not come for whatever the reason. So that is what I will tell about myself. So I am probably living a bigger size life than what I am supposed to be, probably. Anyway, to talk about myself more, I hail from a middle class family. My father was working in a postal department. He joined as clerk in Karnataka in Shimoga district. And I was born in Shimoga district when he was serving at Sagar, which is a taluka now. And as my father was in central government, he was getting transferred every third year. So we used to get transferred usually in the month of September or October, when the school already starts in May. In Karnataka, it used to start on 23rd of May every year. But in September, when we go, we used to get admitted in a government school, what we call it as number school, because the schools are given some numbers, 20 number school, 22 number school, like that. So we used to get admitted there. And once the new year starts or the new academic year starts, then we used to shift to some better school in the city. Like that it is to happen. So from first standard to 12th standard, I have studied in 11 schools. So I am like a gypsy going from one place to another place. And so I don't have many school children as my classmates whom I know. So I studied in Shimoga, then I studied in the Kolar district, then we went to Tiptur, then from there we went to Hassan, then I went to Bhadravati, which is a taluka. So like this, I studied in 11 schools up to 12th standard. Then through government quota, I got my MBBS from KMC, Karnataka Medical College, Hubli. The building, what you can see behind, is the college where I studied my MBBS, and that was in the government quota. Now it is called as Karnataka Institute of Medical Sciences. So this is about my early education and joining the completing the medical education. Over to you, Sirohi.
Sir, you did your post-graduation from Maharashtra. So how did you reach Maharashtra, sir?
Okay. I completed my MBBS from Karnataka Medical College, Hubli. Then there was entrance examination in Karnataka, which was started that year itself, 1987, the 87-88. And even the postgraduate All India entrance exam also was started in 1988. So I worked for 1 year as a physiology tutor in Bijapur, preparing for all the entrance exams. And through state entrance, I got MD anesthesia. So you can see me. I worked almost for 10 months. I got salary for 9 months there, worked in anesthesia MD. Even I had started my thesis, which was intraocular pressure changes with vecuronium bromide. Vecuronium muscle relaxant was very new at that time. So I had started my thesis also. While I was studying MD anesthesia, I got the letter that I got a posting of orthopedics in Solapur Medical College, VM Medical College. So that was sometime around 15th of September, I got that letter to join before 30th of September. So for initial 14 days, I didn't tell anybody. Last but one day, I was doing duty with Dr. G.L. Ravindra, who is an anesthetist working in Shimoga now. I just shared that news with him. Then immediately he said, no, Shivashankar, this anesthesia is behind the screen job. You should go join. The whole night, he tried to convince me. I was not convinced because I had shifted my parents, because my father was retired at that time. I had shifted my parents to me, stay with me in Hubli. So, and there was no doctor in my family. Anesthesia was a good branch for me. Just purchase flag scan. Then you can go for giving anesthesia. That was the intention behind that at that time. And Dr. Ravindra, informed the head of the department of anesthesia also. He told that Shivashankar has got MS orthopedics, even then he is not going. Then next day morning, I was working in the ENT OT. I got a call from our head of the department, Dr. Birama Gangal. She tried to convince me initially. I was still reluctant why to leave this and go. Then finally, she said, Shivashankar, you are not going to pass anesthesia also if you don't listen to me. That also I didn't budge for that. Finally, she said, if money is the reason or anything else, I will help. You are my son. This is what it made. And my credit of joining orthopedics should go to Dr. Ravindra first and Dr. Veerama Gangal. So that's how I came on the last day. I had to pay back all the stipend I had taken from doing MD anesthesia. I went to the bank, withdrew money, gave that money back, then obtained all my originals, came and joined this orthopedic department, which was headed by, both the units were headed by honorary professors, Dr. V.M. Iyer, past Nails president, and Dr. K.P. Daga of Daga Nail fame. They were both full-time private practitioners, but they were also working as honorary orthopedic surgeons. This is how I came to Sholapur through All India Medical Entrance. Yes.
Okay.
Ashok.
That way you found your father-in-law there also.
Yeah, that was after my marriage. Yes, yes. That was after my post-graduation.
Okay.
Then the proposal came. Then Dr. Iyer became my father-in-law. That was later on. Yes.
Okay. So did you do any fellowship also after your PG?
Yes. After doing orthopedic, because in government medical college, as I said earlier, both were honorary professors. We had no dearth of cases for doing surgery. The first day of joining my MS orthopedics, I had done patelectomy as the first surgery. On the first day, I was not knowing anything at that time, but somebody behind gave me this, remove all these pieces, take incision like this, like that. So that's how that was the work in the department. So after my marriage, Dr. Iyer said, arthroplasty is the one which is not being done regularly in Sholapur, so you should become an arthroplasty surgeon. So I went and worked with Dr. Dolakia in Bombay Hospital for 1.5 terms. 10 months I spent there, one full term and another 4 months I spent there. So I saw a lot of surgeries being done there. Then during one of the workshops on isoelastic hip, which was conducted by Bombay Hospital, Dr. Salman Ali from Birmingham had come. So they were also using the isoelastic hip there. So I was introduced to him, and he agreed to give me a fellowship in his hospital in Birmingham. So I went to England and I spent 4 months in Starbridge, which is a suburb of Birmingham, and I did a isoelastic hip replacement fellowship. Then while in Bombay Hospital only, I had taken the recommendation letter from Dr. Junjunwala and Dr. Saraf, and I approached Dr. Holmes, and he also accommodated me as a initially guest doctor, later on as a AO fellow, and I worked with him for 3 months at Catherine Hospital in Stuttgart, and I saw a lot of trabecular hip, because since he knew that I was more interested in joint replacement at that time, I was usually posted in joint replacement OT, and I saw a lot of joint replacements in the form of trabecular hip, which he had designed. But when I came back to Sholapur, again, I had to fall back on the bread and butter as a general orthopedic surgeon, because arthroplasty was not that much developed. So I had to gradually, I became a trauma surgeon. This is how it happened. So I came back, I worked for a few months only as a lecturer in a medical college, then before becoming a full-time private practitioner in Higher Orthopedic Center.
That's nice. So, and how was the Sholapur technique of interlocking discovered? Something about that story, sir?
Okay, I as you can see, I joined Higher Orthopedic Hospital in 1993. Then in 1994, Dr. Iyer went to Australia. And then subsequently he went to Bangalore and he settled down there. So he knew that the hospital in his good hands. So what happened was, while doing the hospital was the first one in private setup to have a CIAM in 1988. Dr. Tanna was the first person to get the CIAM, and Dr. Iyer was the second person in India to get the CIAM in a private practice. Since 1988, our hospital had this. So I had joined in 1993. So I had the pleasure of working with all the latest gadgets and everything from day one itself. I have done so many closed K-wire fixation, so many closed reductions, percutance fixation like that in that time. And when I did my first femoral close nailing, I I presented in our Solapur Orthopedic Society meeting, but there was not much because people were not much interested to know the technique, or somehow there was no, or something else was more important at that time because it might be the fag end of the discussion. So they were not interested to discuss anything. And Dr. Bandari, who is now in the IOA Executive Committee, so he just commented, Shivashankar, this close nailing is only for you. If we get a case, we will refer to you only. This is a casual remark he did. I took that as a challenge. So what I did was, we were putting a guide wire inside the nail to confirm whether the interlocking hole has been filled by the screw or bolt at that time. We were not having bolt. We were using only 4.5 millimeter cortical screws. So we were passing and we were doing that. I extrapolated the same. So what I did was, like we used to open the fracture and push a Kunscher reamer, and which used to come out from the piriformis fossa. Then we used to reduce the fracture and pass the nail into the distal canal and hold a similar size nail and mark. This marking over the time, I made it more perfect. As you can see, the nail is more in anterior aspect. So anterior 1/3 and posterior 2/3 is the junction where you have to make the drill. Second one, wherever the K-wire was touching, that is the x-axis, and anterior 1/3 to posterior 1/3, 2/3 is the y-axis. So I used to make a small hole with the drill and feel with a K-wire which is passed. Once the K-wire goes inside, I used to pass a guide wire from top. When the guide wire touches the K-wire used to wobble. We could hear the sound tick tick. So this is how it started. You can see that while passing the K-wire, you will get a feeling that you are dipping into the hole. You can hit the nail and you can dip into the hole. And when the K-wire touches, you can see the dancing, that is visual. You can hear the tick tick sound, the auditory. Vibration you can feel, again the skin perception. And finally, you can measure the length of the guide wire which has gone inside. So while we take an X-ray, we take AP and lateral, two views. Why? We should be 100% sure that it is not missed in another view. But here I am giving 5 ways. You can use all your senses. You can see, you can hear, you can perceive, you can confirm, so many things you could do. This is how the Solapur technique became popular. And once I started doing them, and especially our Shyam at that time in the early 90s was very not good. Many a time it used to break down at least once or twice a month. And it used to happen usually during surgery. So this technique of guide wire sounding became more easy for me to confirm, and it also reduced the radiation. And people started calling me to do this surgery from other parts of Maharashtra. This is how this Solapur technique came. Yes, over to you.
Yes. Yeah. Okay. So you have conducted many workshops across the country.
Yes.
So what motivated you to do these workshops?
I don't know. First, I did at so many places in Solapur, nearby towns. I did this surgery on complicated femurs. They used to call me because that was the time there was not much Shyams available. And then I came out with this video cassette, VHS cassette. I went to Bombay 3 times, recorded in 3 sessions of 8 hours, and we came out with a 30 minutes cassette, and which was distributed to all the orthopedic surgeons along with the interlocking set by Yogeshwar Implants. And people started calling me for doing workshops. The first workshop I did was at a nearby town, that is Latur. About 15 people attended. That was in 1995 December. But the major workshop I did was first, it was in Nagpur. As a part of Golden Jubilee celebration of Nagpur Medical College, I was invited. You can see Dr. Babulkar, Dr. Iyer, and the Dean of the Medical College. That was in 1997 January. And about 250 delegates attended that. In front of them, I did the femur nailing and tibia nailing without the X-ray or without the Shyam. So I got good confidence because I was just about 32 or 33 years old then. I was not very senior. But once that confidence came to me, then there was no look back. There are people who wanted to call me at so many places. This is in Bilaspur. Again, in 97 only, we went to Bilaspur. We demonstrated the surgery as well as bone model. Then in 97 October, we went to Chandigarh. You can see Dr. Nagi here, and again about 300 people attended that workshop. Then Pune, Sholapur, Panji, Goa, Kolhapur, you name the town. I have visited so many places. Even Thane. In Thane, we had Dr. Rajat Verma, son of R.C. Verma, past Vice President of Indian Orthopaedic Association, who expired yesterday only. A very senior orthopedic surgeon. Dr. Rajat Verma is now in Indore, but he was in, now he is in UK, but earlier he was in Indore. So you can see the workshop was planned in Thane for 100 people, about 170 people attended, and all of them had to stand and see the live surgery and do the workshop. Whole day, there was nothing else could be done. But this all happened everywhere. We used to plan for 50 people, 100 people used to come. When we used to plan for 100 people, 200 people used to come. So went from places to places. I have conducted at least 6 workshops in Visakhapatnam between 1998 to 2010. This is another picture from Visakhapatnam Government Medical College only when I went to demonstrate the recon nailing and endus nailing in children. So I have conducted workshops in Silchar. Silchar, for your information, is beyond Bangladesh. So from Calcutta, we fly over Bangladesh and then we have to land in Silchar. So Silchar in east to Sidhpur. Sidhpur is a small town. It's a taluka place in Gujarat. So from east to west, I have done. From north, Chandigarh to Coimbatore south, I have done the demonstration, live demonstration surgeries in all these places. There is no end for that. So this is how I've been conducting. I have lost the count. Is sometime in 2005 or 6, I had done about 310 workshops all over India. But subsequently, I stopped counting. I might have done anything between 500 to 700 workshops. Yes.
Okay. But you are good at photography. So you have your photographs, very old photographs also with you. That's good.
Yeah, I like to take photographs, preserve them because it is useful at some time or the other. So it's always, I insist the organizer to share the photographs with me after attending any conference. But I get only from about 25-30% of the people only. Not all the people will share the photographs.
I met you through the nails.
Yes.
And you have been a backbone for the nails for so many years from the foundation itself.
Yes.
So I would request you to tell something about the foundation of nails in India.
Yes. Since we, myself, Dr. Iyer and Dr. Rajat Verma, we started conducting workshops together, and our problem in India was entirely different. Our medullary canal was narrow. The thinnest nail, femoral nail available at that time was 13 millimeter, for your information. So none of our Indian medullary canal used to accommodate a 13 millimeter nail. So a 9 or 10 millimeter nail, what we were using, and the substandard quality of the implant which we were using at that time, there are a lot of complications. So we thought to discuss our own problems, instead of extrapolating the Western literature to our India, we thought we should form our own association and discuss our problem. So that's how Dr. Rajat Verma, who was in Indore at that time, now in London, myself, and Dr. Iyer, who was in Bangalore at that time, now again is back to Sholapur. 3 of us met and discussed in IOACON Jaipur. So we took a decision that we'll form an association, and Rajat Verma took the lead and he called the first meeting in February in Indore itself. Unfortunately, 1 week prior to that, there was a Bhuj earthquake. There was a lot of cancellation happening. So many problems happened, whether to continue with the conference here. There are so many problems associated, but even then we had the conference, we continued with the conference, and it had again about 350 people attending. That conference was inaugurated by then IOA President Dr. A.K. Srivatsava from Agra. You can see Dr. G.S. Kulkarni, Dr. Babulkar, Dr. Iyer, Dr. D.K. Taneja sir, Rajat Verma, all of them attended this conference. A ad hoc body was formed with Dr. Iyer as the founder president and Dr. Rajat Verma as the founder secretary and myself as the founder joint secretary in Indore itself. And this ad hoc body, we started getting the members. We had Dr. N.K. Agarwal from Ludhiana as president-elect, Dr. Rajgopalan from Bangalore as the vice president, Dr. S.C. Goel as the executive committee member, Sunil Kulkarni, VP Mida. So many people we had on our board. And we were installed in the second NailsCon, which was held in Bangalore in 2002 by the then IOA president, Dr. Sunil G.S. Kulkarni sir. Then the 2003, Dr. S.C. Goel took the charge and he organized it in Varanasi when Dr. Praveen Kanabar, who was the president of IOA, then attended. In 2004, Dr. N.K. Agarwal organized it in Ludhiana, where the IOA president, Dr. Nagi, attended as the chief guest. 2005, we had it in Pune. Dr. K.H. Sancheti, then IOA president, was the chief guest. 2006 is a very memorable year for nails. Dr. Ravindran organized it in a last minute. Hyderabad was supposed to organize, but they couldn't do that somehow. And Dr. Ravindran organized in 2006. And 2006, the Mailwar Natarajan was the president of IOA. He saw we had prepared for 350 people and we had over 500 delegates. We had to literally change the venue. We had planned the NailsCon in a resort, but that hall could accommodate about 300 people maximum. But since the registration went beyond 500 people, myself and Ravindran went in the evening and booked the Citra auditorium next day. You can see that was the thing which response we were getting from the delegates. And 2007, we organized in Goa. That was Dr. S.C. Goel himself was the IOA president. Then Agra 2008. Then Khajuraho when I was the president 2009. 2010 Kolkata, where I gave the oration. Then Udaipur. Then Chennai, Udaipur, Nagpur, Varanasi, Kaziranga. And then it finally came to Solapur. Solapur never had a 5-star hotel or a good big capacity hall. So once we got a 5-star hotel, we conducted, again about 430 people attended this conference. Then we came to Ashok Sirohi at Corbett also in 2017. 2018, it was in Vishakhapatnam. 2006 is a very memorable year because when Dr. Mailwar Natarajan was the president, he saw the number of people attending and he immediately said in the inaugural function itself, so many people are interested in this nails, interlocking surgeries. He should get the subspecialty recognition in IOA, and Dr. S.C. Goel took that further, and during the tenure of Mailwar Natarajan itself, that nail was given a recognition by IOA as a subspecialty. And we had the first subspecialty meeting in Delhi in 2006. So this is the life I was associated with nails. So this is how, and I'm still the permanent treasurer of the Nail Association as of now, because I had to file the income tax returns of the association at Solapur. So I have kept the post with me only. Yes.
Yes, I was associated to nails since 2003 from Varanasi.
Okay.
Then onwards, I am attending it, barring 1 or 2 places.
Yes, that's correct.
So your contributions to orthopedics have been immense, sir. Would you like to tell something else to our audience about your contributions to orthopedics?
Yes.
In short, sir, only.
Yes, I know.
Because we are starting our academic session now.
Yeah, correct. So there are so many contributions to orthopedics apart from the Solapur technique of interlocking, Solapur sleeve for keyhole surgery, Solapur DHS, Solapur frame. So this is the Solapur sleeve which I have patented. This is the only instrument I have patented, and through which when we are reaming, it definitely helps in reducing the trauma to the soft tissue, and also you can see that the incision is very, very small. So this is the sleeve which I have been using both for retrograde femur nailing as well as prograde femur nailing, and even for keyhole DHS. So you can see that it is such a small incision. I'm able to put it. Again, this whole video of this keyhole DHS, how I do, is available on YouTube. So my incision is less than the 2 centimeter many a time nowadays. So this is another contribution. I have modified all the instrument. Then Solapur broken nail extractor is something which I worked between 1999 and 2004 and came out with this in 2005. This Solapur broken nail extractor, but I couldn't patent this because already it was in the public domain. And when I told this story in one of the workshop in Aurangabad, then Dr. Tanna asked me to write about this Solapur nail extractor, and I got the due recognition, if not the patent, and that is published in his book. Then Solapur frame for distal radius, another thing which I have been working since my residence days. It decreases the number of pins which we are putting. Only 4 pins are put, and because of the crisscross arrangement, the angle between the shank pin is more than 90 degrees. If it is less than 90 degrees, it becomes a uniplanar fixator. So this becomes a quadriplanar fixator, and you can give palmar flexion, ulnar deviation, whatever you want, you can give and you can fix it. So reduction, once it is obtained on table, is not lost. See, here it is a Barton fracture. You can say it's the Ola Smith fracture. You can see such a beautiful reduction you can get in this. So just once you get the reduction, you tighten the clamp in that position, and the patient will have an uneven fill, because in plaster the fracture gets displaced. Here it doesn't happen. So the another innovation is a Asni screws. There are a lot of Asni screws lying with me. Then I just asked one Kshirosagar orthodeal to make some bike, one which can be compressed from both the sides. So here I have used this condyle fracture. I fixed with both the sides. So it will have a good purchase, and you can compress the fracture, because in osteoporotic bone, just with some one-sided threads, if you try to compress, the compression may not happen. So this is another case you can see which I have used, and to help in compressing the fracture from both the sides. Another thing what I have been doing is primary antibiotic coated interlocking nailing. The reason is I keep getting patients with open fracture who come to me at the end of 2 weeks or 3 weeks with pouring pus. They are admitted elsewhere. Once the pus starts coming out, then they come to me. So if I tell them that I'll be doing 2-stage surgeries, I'll put an antibiotic coated K nail first, then I'll remove and put an interlocking nail. Many of the people just disappear, and because one of the reasons is economy. The area I practice, the nearby area is a rain shadow area, so there is not much of economy in this area. So I had to curtail the economy also. Instead of doing 2 surgeries, I'll do it 1 surgery. You can see I use the antibiotic interlocking nailing, and the fracture unites without any problem. This I have been using since 2005, I think. So here, this patient with a compound open injury of the knee and patella with a silencer wound came to me with hip fracture and leg fracture. I used a primary interlocking cement coated nail. You can see I have fixed all the things. I had done the patelectomy at the time. This is at the end of about 9 months when the patient had come to me with the fracture united. So the advantage of this is a single surgery. Even 2 days back I did. On 3rd May, this patient came to me where somebody had taken the patient for surgery. The history is long. The patient had undergone 7-8 surgeries in the last 1 year. The last surgery was external fixator. Again, that also the fracture didn't unite. So the second surgeon took him for surgery, and he opened that fracture. There was pus. So he just packed and sent the patient. So this patient came to me. I prepared an interlocking nail with antibiotic coated in this fashion, and I have put this. I think the surgery I have done on 7th May only. It is not even 1 week. So last week, this patient is still with me. I added also stimulant beads. So you can see the interlocking nail being used. So I have done about 10 to 15 cases in the last 15 years. I don't do very frequently, but definitely this is how I have been doing. Whatever the surgery I do, I like to share, because I cannot come and operate at all the places. I share my tips and tricks with the help of this newer technology like CDs I was distributing earlier through many of the companies, but nowadays over 50 of my videos are available on the YouTube. You can search for Dr. Shivashankar, or even on the YouTube, any of the technique you search, you get the way I do it. and all the videos have been edited maybe. And normally I give the video commentary during surgery itself. It's not dubbing done later on. It's a live surgery. You can enjoy them. Okay, this is about.
That's good. Appreciable, doctor. Appreciate. Would you also like to tell something about some free camps you have been doing in African countries?
Yeah, I think
I've
the
heard
time.
it about.
Yeah.
But if you think that the time is running, we can come to your talks also.
Yeah. I'll just talk about some. See, I have done free camps with not even Africa. I have done in Uttar Pradesh also. Can you recognize him? Anybody? Because he is from Uttaranchal.
No, we were in which city you have gone to in Uttar Pradesh?
No. Can you recognize this person from Uttarakhand, your area?
Yes, he's Dr. Bhandari.
Yes, DK Bhandari and Mrs. Bhandari Suksham. She is anesthetist. So we have done many camps at Hapur, Moradabad, Rampur, Pilibhit, Raebareli, etc. He has attended few of them with me. Then I have gone to many African countries. See, a polio patient crawling like this, I did a release of the hip and knee muscles and gave a caliper and I made the patient walk. This lady, you can see such a bad deformity. I did a triple orthodesis and corrected the foot and gave her also caliper because there is no muscle power. So she will have a foot drop. To prevent that, we prepared caliper and gave it to her. And my services in Africa has been recognized in a Rotary Handbook of the Volunteers. It's still there. So here in Masaka, I had gone. I used to visit villages and see patients and bring them and do the surgeries in the hospital. I have gone so many times. Uganda, Ethiopia, Tanzania, Nigeria, you name many of the African countries, many of the places, even though I didn't go, but I was involved in arranging the medicines, others, and getting the data from there, all those things I have done. So over the last 20 years, I have visited 12 times Africa. This is the first time in August 1998, I visited Uganda. In 2018, we went there again to celebrate the same 20 years of our visit to Africa. And myself, I have done over 700 surgeries in 20 years in these various camps in Africa. It was all through Rotary International. Yes.
Okay, so Rotary had given a good platform for you, sir. That's nice, sir.
Yes.
And you reciprocated the same.
Yes.
That's nice, sir. Myself also, I have been also a Rotarian for the last 20 years, sir.
Very good. Glad to know that.
Okay, sir. So before we come to our academic session, sir, let me tell something of your mountain treks or other extra curricular activities, and then we come on to the hip, sir.
Okay, I'll just go to that slide before, because I don't know where it is. Yeah, so I keep going for trekking every now and then. So since 2008, I have been doing the trekking, and I have gone to Rupkund, 16,500 feet. I have submitted the Mount Shitidhar near Manali. This is 18,600 feet. Then this is Manali. Then Adi Kailash. This is at 16,200 feet. While going to Kailas Mansoor, it's en route. It comes Adi Kailash and Own Pabarth. And I've done the Kailas Parikrama, which is between 16,000 to 18,600 feet when we pass that pass. Then Amta Valley. Recently, I went to Kedarkanta recently after the lockdown when the Uttaranchal state opened up for trekking. That was on 15th of October, they opened up. And I was in Uttarakhand on 23rd of October itself. I did interact with Dr. Hemanshu Kochhar at that time while going through Dehradun. So this is how every year I've been going to trekking that keeps me fresh.
Half of them are in Uttarakhand only.
Majority of them are Uttarakhand. Or we also go to this Himachal Pradesh, Leh we have gone, but since I was taken only few photos here.
But mainly in Kumaon region only.
Yeah, Kumaon
That's
region,
nice.
yes.
Yes, yes. So, Dr. Shiva, now I would like to request you for your academic session for A to Z of intertrochanteric and hip subtrochanteric fractures.
Okay. Actually, it was supposed to be 75% for the talk and 15% for the interview, but it has become reverse. Already we have finished 75% of the talk. Anyway, friends, in 1997, this proximal femoral nail was designed and it came in the market. And I had the opportunity to working as a Indo-German Orthopaedic Foundation Fellow in Düsseldorf in 1999 for 6 weeks. When I went there, I saw the PFN being done. I learned the technique assisting there as an observer there. And then when I came back to India, I had taken a lot of pictures. I shared these pictures with a local Indian manufacturer. And this is the nail which was given to me in 1999. So I used it for the first time, the Indian made PFN in 1999, which was totally designed by me. So though it is copy of the original synthesis product, but I thought whatever the size which is better for Indian version, I did it, and it has not changed since then. Then in 2003, I met Dr. Gadegone. So he had also started doing for intertrochanteric fracture PFN, and he had a problem, especially in curved femur, putting a straight nail of 25 centimeters. So he asked me to reduce the size of the nail to 18 centimeter. So in 2003, we came out with a 18 centimeters nail. So because 24 or 25 centimeter was too straight at that time. So I have been using either TFN or a long PFN since 2004. And very rarely I use a 25 centimeter nail because I also feel that it is a too straight a nail for a curved bone. Then you can see some of the cases. This patient, 85-year-old man, intertrochanteric fracture. I fixed the PFN, and you can see the patient is walking on the next day itself. This is a 10 weeks post-operative when the patient had come. Beautiful reduction, beautifully the fracture has healed. The patient was so happy. He cried in front of me saying that he never thought that he will live to meet me again. So he was very, very emotional. Another case, 75-year lady. Again, you can see there is hardly any posterior cortex in this patient. I used a Halifax nail. You can see there is hardly any posterior cortex. Again, I make the patient walk. So as soon as the patient is comfortable, the patient will be made to stand and walk. And this is at 3 months. You can see the bone which was missing has been formed. And at 8 months, nice consolidation, nice neck shaft angle, good functional outcome. This is a case I have done last week only. You can see again, 89-year-old lady, 89. I'm just showing some of the cases. Beautiful reduction, beautiful alignment, beautiful position of the neck screw. I made the patient walk. This is just 2 days after the surgery. The patient is able to walk. If you have done surgery, the patient should be able to walk. This is what I feel. Because if you are giving plaster or if you are making the patient lie down in the bed, then it's not worth doing the surgery. So let me talk only about few things instead of A to Z of orthopedics. Let me talk few complications which I normally see as the commonest. The first and foremost mistake is varus reduction. This is due to problem with the entry or with the position. Second problem I see is inability by the surgeon to pass both the screws. So that is one of the reasons why people are more comfortable in using a single screw system. Third component problem I see is lateralization of the shaft or altered hip mechanism. Though the fracture unites, you can see that the shaft has become lateralized. The patient will never have a good walking mechanism. So all these problems are due to problem with the position or entry. So let's discuss about the fraction reduction, position and entry site in this today's talk. A fracture like this, with widely displaced neck, what I normally do is I percutaneously insert a Steinmann pin at the fracture site, get the alignment, anterior alignment right, and fix with a K-wire. Once it is fixed with a K-wire, you can see the anterior alignment is good. Then additional wire I pass, both the K-wires are very anteriorly placed, they are in the neck. Then because both the wires are passed, the fracture is fixed, you can adduct it. Because of the adduction, doing a surgery is easy. Without adduction, if the fracture is abducted like this, then passing a nail will be difficult. With adduction, passing a nail will be easy. Another thing I normally do is I keep the perineal post against the opposite or the normal side ischial tuberosity so that the thigh can be adducted. And also I apply a sticking plaster so that the patient will not fall on my operative side when the traction is given. And I also tilt the table. You can see about 15 degrees of tilting of the table I do so that the neck will be looking horizontally. This is the case I have done yesterday only. Just yesterday I took a picture just to show with you. You can see the opposite hip is flexed and abducted, and against the ischial tuberosity, my perineal post is there. Then I have put a small sandbag on the table and I have already fixed that with a sticking plaster so that the patient will not go, because many a time the patient again slips on that side. To prevent that, you have to put a small bump or a small sandbag on the table. This is second thing. Third thing is, here you can see the abdomen is coming in the way. Abdomen fat also comes in the way of good X-ray picture. So I have applied a sticking and to pull the abdomen fat away while doing a surgery. So once you have fixed the fracture, you can adduct it so much and you can do the surgery. This was a demonstration surgery done during one of the operative nailing course. You can see that the neck was displaced. What I am doing is I am putting a Steinmann pin at the fracture site. Once the Steinmann pin is at the fracture site, yes, now the Steinmann pin is getting deep into the fracture site. I am just elevating the neck. Once the neck is elevated, see, the neck has come in good alignment. So this alignment, anterior alignment, is very, very important. Once you get that alignment, immediately fix the fracture with K-wires. So I am fixing the fracture with K-wires. This article has come in 2015 December, provisional fixation with K-wires or Steinmann pin to give if for unstable fractures. But friends, I have been using this technique even in this video of 2005, which was attended as a moderator by Dr. Tanna and Gadegone. This video from the cassette, you can see I've been demonstrating that K-wire. You can see that there is a 2 K-wires which I've used. Since the K-wires are not there, I used a guide wire itself, guide pin itself as to fix the fracture. And it was a undisplaced fracture. This was an undisplaced fracture. You can see for an undisplaced fracture also, I have used this K-wire fixing in 2005 itself. So unfortunately, I have not done any paper presentation on this in any international journal. That's why my name cannot be given to that. And coming to the next, the reduction, beak should never be inside the medullary canal. This also I have been shouting in all my conferences, saying that beak, if it is inside in a nail, means it is varus. So never get the beak inside. This is a negative medial cortical support. Neutral are touching the neck, and this is a positive cortical support. Again, these have been advocating, at least for the last 15 years, I have been advocating that the beak has to come out. I have been telling every time that diamond Houston osteotomy can happen only with an extra medullary surface implant and not with an intramedullary implant. This is a negative cortical support. This is a neutral cortical support. This is a positive cortical support. This is 2007, you can see positive cortical support. Then this positive cortical support has to be not just in AP, it has to be in lateral picture also. See, here you can see it's a positive cortical support in AP picture. But if you see the lateral picture, you can see that the beak has gone into the neck. So because the beak has gone inside the neck here, the beak subsequently has slipped inside and went into failure. So that's why you should get neutral or positive cortical support even for the neck. in the lateral view. This was a 2010 picture. You can see beak had gone inside. Another surgeon was doing the surgery in Sholapur. He called me. I went. What I did was I saw that beak is inside. I said, this is not acceptable. I took a bone hook and I pulled the trochanter out, got the neutral reduction. Then I finished that surgery with a nailing. So this is after this immediate post-operative picture, such a bad comminuted fracture. This is, you can see, December 11, 2011, you can see the fracture has consolidated beautifully without any problem. So understanding the principle is more important. Not putting a nail and fixing is not just, it is not like that. You have to, we should know the biomechanics properly. You understand it well, then it is good. Again, this case, a 15 days old fracture, a positive cortical support I have obtained in 2007. After 14 months, you can see beautifully the healed. Even in such a osteoporotic bone, the screws are not backed out because I achieve compression on table judiciously. I keep pressing the screw, tightening till I am satisfied. So this is about the reduction. Coming to the entry point, all these nails, the cephalomedullary nail have an entry from the tip of the trochanter. But friends, what happens is the outside bone is weaker when compared to the inside. So when you ream, the outside bone gets reamed. So inadvertently, instead of going from the tip of the trochanter, you go from the lateral to the tip of the trochanter. So reaming gets more done on the outer side, which is a weaker bone. So the position of the nail, instead of being proper like this, because your entry becomes lateralized, your screw position will also be not proper. Your screw, which was earlier inferior in the neck, inferior in the head, becomes, though inferior in the neck, it becomes central in the head. So this is what we should not accept. Another problem I see is people push the nail through the fracture site. Because there is a fracture, they push the nail. This acts as a spacer. So which implant, where you put an implant at the fracture site, you tell me. You should always make a canal for the nail and don't just shovel the nail at the fracture site. So this is the correct way. You should make a 15 millimeter hole in the bone without using a centering awl. You should never ream it. So nowadays, what I do is I go a step further. I use this cannulated awl, which takes out 10 millimeters of bone. Once I take out 10 millimeter of bone, I use another cheese cutting instrument. This is another case you can see. A beautiful reduction I have obtained. Then I have made an entry from medial to the tip of the trochanter. This is the cheese cutter. It comes in 10 millimeter and 13 millimeter. Here I am using a 10 millimeter cheese cutter because the bone was very osteoporotic. Then I pass the cheese cutter, then take out the guide pin and I pass the long flexible guide wire. Then I use the 15 millimeter centering awl. I pass it properly. Then I use the centering awl and then pass the nail. Because I have done such a laborious steps of taking out bone of 10 millimeter first, then reaming with 15 millimeter awl, a proper 15 millimeter canal will be there for the nail. Without doing that, if I shovel a nail, again, as I said earlier, it acts as a spacer and it prevents union at the fracture site. So you should never insert the nail without making a hole in the nail. The same patient, 93-year-old lady, operated on 1st March. You can see the patient is walking without any support of any person, just with a walker, she is able to walk. Our aim as orthopedic surgeon is to bring back their morale. They should be psychologically, they should feel that they will be able to walk. Then only they will eat well. Otherwise, what happens is, if they are in the bed, they think that daughter-in-law or son has to give the bedpan, which they will, psychologically, they cannot accept it. And they stop eating food and the complication starts because of constipation. That's the main problem I see in the elderly age group people. So if we are doing surgery, patients should be made to walk with support as early as possible. Where I take the entry nowadays, I take it medial to the base or the neck itself. You can see where the entry I have taken. When I ream, I know that the lateral side bone is weaker. I end up reaming more here. So after reaming, you can see I have ended up reaming more. When you see finally the guide wire, it is seen in line with the tip of the trochanter. This is what we want. So my reaming is medial to this guide wire, but you can see because I had taken an entry from such a medial point, my reaming has gone properly. Then my nail will sit properly. My neck screw is inferior in the neck as well as inferior in the head. That is the crux of the treatment in these fractures. What happens if you take the tip of the trochanter entry? See, such a beautifully reduced fracture, a subtrochanteric fracture. When the surgeon has taken an entry from tip of the trochanter, the owl is going properly to the canal, but once the nail is passed, you can see the fracture has opened up. The proximal fragment has gone into varus. That is the reason why I say any nail, if you are using, take the entry medial to the tip of the trochanter. Don't think about the 5 degree, 7 degree bend given to the proximal end of the nail. It doesn't matter. Even if what happens is when final sitting of the nail will happen, the proximal fragment goes into valgus. Valgus is what we require. So always try to take the entry medial to the base or medial to the greater trochanter, which is central in lateral view. Misnomer is piriformis fossa. Friends, piriformis fossa is slightly posteriorly placed. This is for a curved femur nail. We take the entry much more posteriorly. But for a PFN, we have to take an entry in the lateral picture in the central part. So passing the nail at the fracture site is the problem, as I said earlier. So what happens normally is the surgeon keeps the fracture is very well reduced. He adducts it. The thigh touches the perineal post. Even if further adducts it to pass the nail, fracture opens up superiorly. Even if it doesn't open at this stage, when you insert the reamer, because there is no resistance, the fracture opens up superiorly. This acts as a fulcrum against which fracture keeps on opening superiorly. Then surgeon passes the nail. The fracture is in varus. If you fix the fracture in this position, it will be in varus. But sometimes what happens is surgeon realizes there is a varus of the neck. So what he does it, he abducts the limb. When he abducts the limb, fracture which has opened superiorly, now against the nail, fracture opens up inferiorly also. This acts as a spacer. So how you can recognize it? If you see the length of the screw, if any screw is more than 100 millimeter, that indicates that there is some problem. You have to go back and see. 100 millimeter screw is only required for some 6 feet, 6.5 feet tall patans, not for ordinary people like you and me who are 5.5 feet tall. So here you can see a 100 millimeter superior screw and 110 millimeter inferior screw has been used. What has happened here in this case? See, there was a fractured pelvis and the surgeon has adducted the limb and then abducted and put the nail. So much of lateralization of the shaft has happened. How you can measure? Normally, if you draw a line from the outermost part of the pelvis, the greater trochanter grazes that line. Here you can see when that line is drawn, greater trochanter is almost 2 centimeters away from that. That is how you can recognize lateralization of the shaft. Just because you are using a modern implant doesn't mean that you will do the surgery properly. You have to give proper importance to each step. Here you can see the greater trochanter, the distance from the joint to the greater trochanter, here it has increased. There is lateralization of the shaft. If you measure the line, you can see that the blue line, it is grazing on this side, whereas on the right side, so much of lateralization has happened. So the biomechanics of the hip, the lever arm of the hip is all mismatched. So the patient can never function. Then, as I said earlier, I always compress the fracture. Initially, I have released the foot and traction and alternately superior screw and inferior screw I compress on table so that the screw should not back out. This case, I just yesterday evening only I operated. This 10th May, this patient came and I have operated on 12th May. This was a plain fracture. You can see a intertrochanteric fracture. I was thinking whether I should do a keyhole DHS, but when I took the patient on table, there was a lateral wall fracture also, which was not seen earlier. Whether it is during positioning of the patient has happened or I have missed it on this, I'm not sure. But anyway, So here what I did was I fixed this fracture because it was widely opened like this. What I did was I inserted the inferior screw first, then passed a Steinman pin medial to the beak, tried to reduce the gap here, and finally after doing the nail, I finally fixed that with a cannulated cancellous screw of 4 millimeter diameter to get the alignment right. This is a good valgus I have obtained in this patient. This is today morning's picture. Patient is sitting and the right side leg is doing the quadricep drill, and on the left side is the operated limb. So I teach the patient the next day itself. You can see the patient is doing the leg straightening. So she's able to do. Now tomorrow I'll make the patient walk. Today I already made a stand with the help of walker, but tomorrow I'll make her walk. So this is the immediate post-operative X-ray in the same patient. So taking care, this patient is 78 years old. So doing surgery is not the only thing. Doing it right, knowing all the steps properly without missing any of the steps, understanding all the things which can give good results is very, very important. You can see about 10 commandments of intertrochanteric fracture, which I have posted on YouTube, and it also has come as an editorial this in Indian Journal of Orthopedics. The 10 commandments are good reduction, good implant from a known company, good anterior reduction, good medial reduction, neutral or positive cortical support, proper entry after reaming to make the canal in the nail. The nail should not act as a spacer. Good screw placement both in AP and lateral position. TAD less than 25 millimeter both in AP and lateral picture. A fracture which is very well compressed, because if you don't compress the fracture, the screw will be remaining out, and that screw will start toggling. That toggling of the screw will cause loosening of the fixation. So always compress the fracture judiciously on table. In headless screws, the back end of the screw should be slightly out so that they can slide out during the fracture collapse. The nail should be slightly projecting out at the entry side. These are the things that are very, very important. Let me go back. See, a beautiful reduction, valgus reduction, good anterior reduction. You can see good anterior cortical support, good medial cortical support, good positive cortical support here, good position, inferiorly positioned, good subchondral horn, both in AP and lateral picture. The nail is slightly out at the entry side, well compressed fracture. You name, I have obtained everything. So this patient is going to do very well in her future. So I'm not worried. In spite of that, I do know that about 5 to 10% of the fractures do give trouble. But at least we should be having a good night's sleep when we do a surgery, and we should be happy that we had done an excellent surgery. So this is in short about PFN, but there are a lot of YouTube videos I would like all of you to go through them, because many of them are over 2 hours long. They especially just deal with some of the talks like how to avoid common mistakes, how to avoid Z effect, then which is the best implant, which is the gold standard implant, which is the best available intermediate implant for the hip, how to do an intertrochanteric fracture, how to do a subtrochanteric fracture, how to operate on a orthopedic table, how to operate on a simple table. All these are videos. I have at least 50 interlocking nailing videos on YouTube, so you can see them, and definitely it's going to help. Thank you very much. I hope, yeah, I have finished in about 25 minutes time. Yes, we can have some discussion, no problem. That will be more important than talking from one side. Yes, Sirohi.
I would request the panelists to unmute, and there must be some questions. If there are some questions from the audience, Dr. Hemanshu and Dr. Puneet, we have given your WhatsApp number to them.
Can I ask a question, Dr.
Yes,
Shankar?
sure. Yes,
Yeah,
Govind.
excellent talk. I mean, your experience will help us. And naturally, we have not done the amount of work what you people have done. I do find some problem. I'm mainly an arthroplasty surgeon, along doing a bit of trauma as well. My problem is elderly age group patients, marked osteoarthritis of the hip, and they have unstable intertrochanteric fractures. We know we tend to do a bit of a nail. Reduction becomes difficult because there's not even a movement available to accommodate and reduce the fracture in a significant arthritic hip in an elderly. I find DHS is a good option because you do an abduction most of the time. In nailing, you need to abduct the hips.
Yeah.
And I find difficult and it was a challenge. What is the answer? What do you do in those cases?
Fortunately, we don't find so much of hip arthritis in India when compared to, yes, since I have worked in England for 6 months, I know we do a lot of hip arthritis there, but here, luckily, we don't see them. One. Second thing is, what you are doing is right. Means even if I see an intertrochanteric fracture with arthritis which requires a hip replacement, my primary aim is to get the osteosynthesis first and then put a primary replacement processes rather than a revision processes in day one itself, and try to use the fracture as an advantageous situation to do a replacement surgery. This is my way of thinking. And as you rightly said, I do agree that it's good to do a DHS in them, get the union first, then anyway you are going to do the replacement after 3 or 6 months time. Go ahead and do it as a fresh case.
Yeah, I think absolutely right. That's what probably I go for. I never believe in primary replacement in a fracture. There is a big wave of people moving in India as well as, I think more so in India, for unstable doing. I don't agree with it, I have to be honest.
Yeah,
there's much more.
that's one of the reason why I showed 80 plus cases. Majority of the videos whatever shown is 85, 90 years old. Only the reason is the people should understand that these patients can be made and brought back to their pre-trauma level by doing a proper surgery. This is my only intention of showing all those videos.
We need to salvage the bone to do a joint replacement and not keep on adding revision on day one.
Yeah, the complications of revisions are much more problematic than a complication of a osteosynthesis, because if the osteosynthesis fails, you have a better area to do a replacement job. But if a replacement fails, I think you are doomed.
Right, thank you.
Dr. Puneet, we cannot hear you.
No, we cannot hear you. You can remove that. You are not enabled. You are not enabled your instrument with a microphone. So better is to take out the earphone and talk directly to the computer. Yeah. Unmute
yourself.
Yes.
Unmute yourself.
Yes. No, your microphone is not enabled. So go to the next to the mute button. There is a select audio, select speaker. There, go to the headphone, test speaker, internal microphone you have to connect. Select microphone.
Dr. Hemanshu, you can ask meanwhile.
Dr. Shiva, you have done so many of these hips. Is there any need to do some anthropometric study under the aegis of IOA to see that what kind of demographic profiles, like if we see in Uttarakhand, the height of the patients is quite less, and then if we see the people in Maharashtra, like the hips, the morphology of the hip varies from region to region.
Yeah, yes.
So can, under aegis of IOA, we can collect a data that how our hips are there, and then we can design our own. Like I know that there are many versions of these PFNs are already there.
Yes.
In certain individuals, in certain ladies, like even a reaming of 15 mm is just you are taking out a lot of bone.
Correct. I do agree with that. Especially central India, the sickle cell patient, they have got a more curvature of the femur. Then if the ladies, as the age advances, that bowing increases. So yeah. So at present, what we are doing is IOA is trying, and it is in touch with Northgate of UK for IOA registry for hip trauma. We are trying to get that. Probably we are already in the final stage of finalizing that. Once that registry comes in the picture, whenever somebody uploads a bilateral hip fracture, means if one bilateral hip X-ray for a fracture of one side, then the normal side we can start analyzing. Probably in the long run we can do that. And at present, I don't think we have anybody doing it. But definitely, if somebody is ready to do that, IO is ready to get the
Another
grant for
thing,
you.
like
Yes.
there's a change in the there is a exaggerated anterior bowing of the femur with the age.
Yeah,
That
correct.
that
Yes.
is there.
Yeah, elderly
And
ladies. Yes.
there is subtle change in the neck profile also. That
Correct.
like if we see patient the neck profile of a 30 or a 40-year individual, you can see it's a fuller neck with a little
Yeah.
bit of anteversion. And
Correct.
if we as we age, the posterior, there is a scalloping of the posterior, like the posterior the cortex of the this neck gets eroded with time. So then you are
Yes.
left with the neck which is almost bowed like that, like that it is eroded from the posteriorly and the anterior cortex remains. So is there any like you need to modify the nail according to that or anything on that, sir?
See, as long this nail is put from the center of the neck in the lateral picture, so it will have some hold somewhere, either anterior or posterior. That's why we don't find it that much problematic. But definitely, if you take an entry which is much more lateral, we have seen that happening in some of the nails where the entry was taken slightly posterior. The nail, the neck screw used to go out from again enter into the neck. That we have seen. That is the reason why while announcing, while I made the point medial to the base of the trochanter, I said that your entry has to be in the center in lateral view. Though from AP it is medial to the base of the trochanter, but when you see in the lateral, it has to be exactly in the center, both anterior and posterior cortex. This is what that's what we have done, but we have not done any study. But definitely there is a place for study. See, I am in private practice. I run a small hospital. It's a single surgeon nursing home. So I cannot do, but a person with a lot of cases like a center with a lot of cases, they can do the study. Another thing I have observed, Hemanshu, our Indian hips, the tip of the trochanter, if you draw a line, it will go out and touch the lateral cortex of the femur. Whereas in a Western people, a European or American person, if you draw a line from the tip of the trochanter, it will go into the center of the middle canal. So our hips are slightly outfed.
Or what we can do like if we take the fuller profile of the pelvis along with the proximal third of the femur,
Yes.
if we take bilateral in a big 14-17 film, in the normal hip, we can see that what is the point which is in line with the canal of the patient. And then we can take a yardstick from there and do the nailing on the other side. Like this is a good injunction because anatomies vary. So that can also be taken like that.
I totally agree. I think that's what the mistake people don't realize. X-ray hip is not X-ray right or left hip. It has to be X-ray pelvis with both hips. On the basis of that, you can get a varus or a valgus, and accordingly, you can choose the size of an implant or the type of implant, what angle you need. Do you need 130? You need 125? And I think that is a valid point. If it's a varus, you have to go for a lesser angle of of these implants. So I think having an X-ray of the opposite is very, very important.
Yeah, Govind, what point I was trying to make was, if you see the tip of the trochanter, if you draw a line, it will go parallel to the lateral cortex here.
That's right, absolutely right. Yeah.
If you see in many of the European, the trochanteric tip will come here. If you draw a line from here, it will go into the center of the metallic canal. So this is what I have seen, because we can see a lot of X-rays on journals and other sites. So that's where I have compared, but I have not done any specific study, but this is just an observation which I am sharing.
That you know why all these people, Western world, they say if you're putting a long gamma nail or if you do like that, go with lateral. If you're putting an intramedullary femoral nail, go medially. But you're absolutely right. I think that's a good observation, which is very different. I mean, if you go to the Chinese hips, Japanese, they're slightly different. So we have got this sort of a thing, and we have to cater our population. But what Dr. Shankar is thinking is very good. I think that's worth going with medial, which a lot of people may not agree, but definitely if you go lateral, I find the top of the nail a bit bulkier. And as you ream, you blow out and you create a bigger spacer.
Yeah,
and that
correct.
may not be a stable reduction.
Yeah. See, what happened is, the literature also, I don't agree all the time. People do femur nailing And as I said earlier, the thinnest femur nail available while I was working in Germany was 13 millimeter. When they put a 13 millimeter nail, they ream up to 15 millimeter. When they ream a neck from the piriformis fossa 15 millimeter, nothing happens. But when they do a PFN, if they ream at the same site, there is vascular injury happening. One article somewhere came in the paper. Blindly, everybody switched over to the tip of the trochanter entry. I am yet to see a problem of vascular injury or AVN of the head happening just because I have gone medially. I have been using only piriformis fossa, means this is a misnomer. It's medial to the base of the trochanter, but central in AP. But I normally call it as piriformis fossa, that's fine. So I have been taking only that entry since last 15 years and I never faced any problem in any of my cases. My experience is not less than 1,000 cases, what I'm talking. So somebody publishes a data from anatomy saying that there are vessels which are going to get injured, and that is the one which prevents us to take that entry. And unfortunately, what has happened is we as surgeon also find it difficult to take a medial entry, and we are more happy using a entry from the tip of the trochanter because it's much more easier. So this is another problem. So we are supporting the people to make a nail which is little more bent. That's the reason why PFN A2 came with lateral entry. The PFN A came with a tip of the trochanter entry. PFN A2 came with a 3 millimeter lateral to the tip of the trochanter entry.
Sir, after reaming, 3 millimeters is hardly anything in that.
That's correct. Once you use a 15 millimeter reamer, then 2-3 millimeter doesn't matter. But as I showed you, if you take an entry from the tip of the trochanter, your entry is going to become much more lateral. That is the reason you take an entry on the hard bone. You cannot go medial to that because the bone is hard. Whatever you are going to remove is outer lateral to that. So you fix your entry point properly.
Dr. Shankar, yeah, I mean, sometimes we see an osteoporotic fracture. I'm just getting your experience because naturally you've seen more. When we want to go medial, and surprise, which you don't perceive or don't see normally on an X-ray, the fracture entry where you start, it's already so much comminuted, and you start reaming, it's already blowing out. What do you do at that time?
That is the reason why I showed this X-ray of a very elderly lady. I'll share that again because it's always better to discuss seeing the case. See this lady, see the age, she's 94. It is written 90 in the X-ray because they just said 90 years. So here what I have done is I have used a centering awl to make a proper entry where I want. The medial end of the blade is touching on the neck. I am making an entry lateral to that. Then I have passed the centering awl. So this is what is required. And these two KYs which are holding the reduction prevents opening up of the fracture. There should be resistance. If your fracture is opening up when you're inserting the reamer, then you cannot ream it properly. So to keep both the surfaces together, these two KYs helps very much. So this is what I wanted to emphasize with this X-ray. See the final result in this patient. Here you can see that the entry is in line with the tip of the trochanter. In spite of all the efforts I have taken earlier to keep it medially, finally, because the bone is so weak on the lateral side, it comes out to that point at the end. So we should decide where our nail should be first. Similarly, what I do when I do a polar screw system for tibia, I want the nail to be on this part. I measure this is 10 millimeter. So exactly medial to 10 millimeter, I put a polar wire so that your nail will be there only. So we should define where your final position of the nail will be. Accordingly, you should go a step backward and execute them properly.
Thank you very much.
Yes, Dr. Indramohan Singh, President, sir. You are muted.
Sir, unmute yourself.
Sir, it was a really eye-opener. The tips and tricks you have told, learned so many things today. I fully agree with Dr. Hemanshu. We have some demographic change in the patients we have. Most of the elderly ladies we are having the anterior bowing and the lateral bowing also along with it.
Yeah.
So what I do is I prefer to make an entry point anteriorly, as you agree, but a bit laterally also. In such cases, when I prefer when I start doing a central placement, so usually it is few of the cases have penetrated anteriorly.
Okay. Yeah, that's what each case is different since your experience is more. Yeah. So we cannot comment unless we see some X-rays. Then
Yeah.
only we can comment. Yeah. Yes, I do agree, but there is a lateral bowing as well as anterior bowing, which is very, very common in elderly females. Yes.
Dr. Puneet?
Sir, is there any role of giving teriparatide after intertroch fractures? Because in the osteoporosis, it is said if there is a fracture of one hip, the other is on the way.
Yeah, correct.
So to prevent that, so what kind of a regimen, like you give denosumab or teriparatide or something else, or anything else which is
See, denosumab is a thing which once you give, every now and then you have to give, then only it will maintain. Otherwise, the day you don't give, again it will
what
go
about
back to the same.
teriparatide?
Teriparatide, at least 18 months it should be given. I am yet to see any one of my patient who has taken even for 3 months continuously, leave about 18 months. So majority of my patients take at the most for 3 months, or I don't know if anybody has taken even for 4 months. They don't come because cost is really a constraint, and our people don't understand osteoporosis. That is the reason why it is rightly said it is a silent killer, because importance is given least to that. But if you give calcium supplements and anabolic steroids and vitamin D3 injections, this is what I normally give. But I have prescribed few patients teriparatide, but none of my patients have regularly taken, to tell frankly.
Sir, can we share, Dr. Sethi, can you share your UK experience?
Yeah. I mean, the teriparatide is so widely being used in India, I find these days, there's no need for that. It's a much cheaper version, as you know. Go for alendronate. Alendronate is a much cheaper. Teriparatide is, when you start, you're all elderly patient, if you start investigating, they'll need it. It's a very expensive medication. Alendronic acid is cheaper. There is a side, the only thing you have to make sure is don't give alendronic acid too long, because then you get bisphosphonate fracture. Yeah. So there has to be 3 to 5 years honeymoon period to stop it. But teriparatide is an expensive. I think there's no need for it.
Yeah, somehow I'm not very keen to use alendronate. One of the reason is I think that calcium has to be replaced by calcium. For example, if you are hungry, you want food. If I give gold, does it do the job? Similarly, when body requires calcium, it absorbs from the bone. So you have to replenish calcium properly by just giving anabolic steroid, the alendronate or any of those bisphosphonates. What happens is you are just making the bone appear stronger when you do a BMD test or a DEXA scan. But in fact, bone is not that strong, because whatever is the strength which is shown is by this alendronate, which is much more brittle. That is the reason why as and when the quantity of alendronate gets accumulated more, bone becomes much more brittle. So that's the reason why we see. So somehow I am myself not convinced to replenish calcium with a alendronate. So that is the reason why I normally don't use it.
No, definitely, you're right. But I think I'm not discarding calcium use at all. Calcium with alendronic acid. Alendronic acid, I totally agree with you. One is to form a ground matrix, which is important way to leave the calcium in. But definitely calcium with alendronic acid. But teriparatide, I think it's overkill.
Yeah. And there are many versions of teriparatides available. I always feel that the original is always best. None of them are as good as, because whatever the process they manufacture, the quality and the clinical efficacy, what we see in the end result, the original is always original. So by changing some process of manufacturing, I don't think we may not be getting the same result. It could be with any molecule, not necessarily with the teriparatide. It could be with any molecule. Just to cut the cost less, they come out with some simpler process and they manufacture. Since the end product is same, they say that it is same. But as you know, S isomers and N isomers, they are mirror images. Though they are same images, but efficacy of this is different from this.
Can I just share one slide for the audience? It may help them.
Sure. Yeah, it will love to.
If I can get them, it is basically because we know nowadays it's a lot of patients getting anticoagulants, blood thinners and all sorts of things, and they do have fractures. If I can get the slide and just a policy which might help people, and you may get a patient who is on dabigatran, rivaroxaban, what should you do? And what is the time of surgery more important to operate? If I can share, let's see if I can.
Yes.
Can you see that now?
Yeah, now we can see.
Yeah, this is actually what policy we have followed the most commonly.
Okay, you are in from Kadardale. Okay,
that's right.
Then,
yeah, Mr. Holder. You know Mr. Holder.
Well. Yes.
He's a good fellow. Yeah.
Yes,
he's not far
I visited his place, Halifax. I visited his home.
Yeah, that's right. Yeah. I'll let him know today. He wants to come to India because of the lockdown. He cannot.
Yeah, he has been coming. Even he came to Uttarakhand for Dr. Sirohi's conference. He was there.
That's right. Yeah. I think this is primarily is a patient who's on warfarin who has got a fracture. Naturally, the aim should be to operate this patient as early as you can. Naturally, you have to optimize the patient, preferably within 24 to 48 hours. If they come on a warfarin, you have to stop the warfarin to get them surgery. But to stop the warfarin, the INR to come down to 1.5 may not be that easy. The way to go for is give them vitamin K, which normally is given at 5 milligram intravenously, and then repeat the INR in 4 to 5 hours time.
Okay.
If you get to less than 1.5, go ahead with the surgery. So you don't have to wait for 3, 4, 5 days to get the INR where you would like to, because anesthetists would like to give spinal, they will not give spinal with INR of 2.5 and so on. So if still you've got 5 milligram of vitamin K and it hasn't gone down, you can again repeat it and again see after 4 hours what is the INR till you get the INR 1.5 or less. This is for, there's nothing wrong. It is a known way to proceed for early surgery, a patient on INR. Now, a lot of time patients are on apixaban because warfarin has got a problem with titrating the INR. Apixaban, rivaroxaban, and there are lots of other things which are being given. When we started doing, when this medication came, we used to stop the apixaban for 5 days, I remember, and operate after that. Now, there is enough literature to say you just have to stop for 24 hours.
Yeah.
So if they normally get in the morning, if you got a fracture in the afternoon, you want to do next day, after 24 hours, you can go ahead, provided the creatinine clearance is okay. The other common is the dabigatran. The dabigatran is slightly more tricky. The dabigatran has to be stopped more than 24 hours. So what you can do is, in that case, you need to get the blood test to see the thrombin time. If the thrombin time is normal, you can proceed for surgery. If thrombin time is prolonged, then there is a way, then you have to wait. So normally for warfarin, in summary, you can give 5 milligram IV after 4 hours CINR. If it's 1.5 or less, go ahead with the surgery, second day also. For apixaban, rivaroxaban, no need to see INR. After 24 hours of her last dose, you can go for surgery. With dabigatran, it is a bit tricky. You need to make sure you need to send the thrombin test after 24 hours. If thrombin test is okay, you can go for surgery. And as far as the dalteparin is concerned, which is usually given around the evening time, so it's 5,000 prophylactic doses which people get on a regular basis. You can stop in the evening and operate in the next day in the morning. So I thought maybe if you're seeing patients like that, you don't have to wait. The scene has changed. We used to stop for 5 days, wait for surgery. Now you can. And nobody can challenge you in the court as well because it's an accepted norm now.
Yeah, that's correct.
Thank you.
Because more you delay, the chances that the patient will be fit again will be less. So it's always better to do as early as possible.
That's good, Dr. Sethi. I appreciate it.
I have a question to Dr. Sethi. When you want to start again heparin, or if you want to give any low molecular after the surgery for an elderly patient to prevent DVT, when you will start?
Yeah. No,
how many hours after? Yes.
Yeah, I'll tell you. It depends what is the reason why the patient goes on warfarin, what is in blood thinners. Is normally nowadays atrial fibrillation is so common. So warfarin in atrial fibrillation is gradually weaning off and they're coming to apixaban because you don't have to titrate the dose, okay? Now, if you've got a metal valve for a reason where you have to bridge it, then it's a different thing. You cannot leave the patient without warfarin or apixaban for a long time. So prior to surgery, I'm talking, the first slide I showed you was for trauma, but for elective, you stop 5 days of apixaban, you stop warfarin for 5 days, and then have an IR on the day of surgery. In that case, you will find after 5 days, it normally comes down to 1.5 or less. Coming to start, when there is a shard scoring system, CHARD, it scores if it's more, the various reason, did the patient had, peripheral vascular disease? Did she had PE? Did she have repeated DVTs in the past? You score more. So if normally the patient's on atrial fibrillation, age will go with them, you score around 2.5. So what you should do is you operate on the day. Ideally, you should give in the evening. I don't give it for a reason. If it's a hip or a knee replacement, my worry is they may bleed more and my hematoma will be a problem. I start next day with prophylactic dose of deltaparin, which is 5,000 unit. We don't use heparin. Heparin is only used where it's a metal valve nowadays. We don't give heparin at all.
Hello?
So you start with a deltaparin, 5,000, and put them onto the normal apixaban or warfarin dose till the INR is back to where they want. So next day I will start.
Okay. Thank you. Puneet, could you fix your mic problem? No.
Hello? तो उसमें क्यों नहीं दिखा रहे? शेयर करो उसके लिए। मैं खोल दे रहा हूँ, खुला हुआ है, ऐसे नहीं दिख पाएगा। तुम करो शेयर।
There is a green button, share screen. उसको दबाने का, then whatever the panel you want to share, click on that.
No, it is open. Screen sharing is open.
No. Yeah, he has to click on the screen share. Then on whatever you want to share, he can share.
Puneet, it is open there.
Has he opened the file or not, which he wants to show? That's important before he shares.
There is some problem in the mic also.
Okay. Then you only take over Sirohi.
How can I share? He has sent a WhatsApp only.
What?
WhatsApp, X-ray on WhatsApp.
I think we can skip that, not an issue. Yeah, we can. If there are any questions, we can take. Otherwise, we can call it a day. We are 34 minutes. We are overshot.
Yes, Puneet, you can share it on the WhatsApp only. I will share it on your WhatsApp. Dr. Shiva.
Yes.
I am sending it to you.
Sirohi boss, अपना जो WhatsApp का X-ray है, can you on that phone, can you put it onto the camera of your, of your computer?
How to?
No, the picture what he send you on a phone, and you can just,
Dr. Shiva will put it. He is more tech savvy.
He knows. So
Has it reached you?
it has reached me. It has reached me. WhatsApp has reached. So
Yes.
okay. Can you see?
Yes.
Okay. This is the X-ray he has sent.
Okay.
This I from my WhatsApp I transferred to my mail. From my mail I have opened it.
Okay. Okay.
that's great, yeah.
See, what you have to do is, this is a high subtrochanteric fracture, and there is a chance of this proximal fragment blowing out when you put a 15 millimeter reamer. It's better to put two K-wires very anteriorly, then put one Steinmann pin, adduct it, and make an entry from medial to the tip of the trochanter. When you pass the Steinmann pin, it should be from the greater trochanter flare from here to inferior part of the head, so that you have lot of place to adduct it. Many a time what happens is surgeon passes it from in direction of the neck shaft angle, so there will be less place for adducting and internally rotating. So one tip is, you start from here, go at 90 degree to the inferior part of the head very anteriorly. That's one. Second thing is, when you adduct it, there is external rotation also has happened. So you have to internally rotate the proximal fragment, then take an entry. The entry should be medial to the base of the trochanter, and your guide pin should go parallel to the lateral cortex, because it's very easy to go medially. If you go medially, you will open up the canal medially and there will be varus happening. So to prevent that, you have to go parallel to the lateral cortex in AP, parallel to the anterior cortex in lateral view. This is how we can treat them. Anything else?
Hello.
Dr. Puneet, could you hear?
Hello. Am I audible now?
Yeah.
Yes. Yes.
Yeah. Thank you.
At the end, you made it.
Delegate want to know way to achieve reduction by closed method, and if we open it, hold it many a times, humans come into way of passing proximal screw.
See, what I said is, getting hold on the proximal fragment and holding it against the distal canal is one, and give traction and pass the guide wire across. There is no problem, because these are all small fragment. If you try to hold it with anything, here if you try to hold the proximal fragment, there is a fragment which is missing between medial and cortex and lateral cortex. You are going to crush and it is going to cause more comminution. So I will only hold the proximal fragment with a Steinmann pin and try to adduct it. That's all I will do.
Okay, sir. I would like to ask one thing, sir. Nowadays, many things are coming in the market to buttress the lateral wall. What is your suggestion for that thing, sir?
There are many things which are coming in the market to buttress the lateral wall, but I use the nail with the neck screw. See, the neck screw should be supported against something. If it is not supported, if the head is loose, then it can toggle and lose the purchase and slide back. If it is against the lateral cortex snugly touching, or if the lateral cortex is missing, it is snugly touching against the nail itself, then the nail itself will act as lateral wall. Can I share a few slides? Dr. Sirohi?
Yes, sir.
If we have time, I can share a few slides.
Yes,
what
yes.
I'm talking. See, otherwise it becomes little difficult.
No, you can share, sir.
Yeah. Actually, I had put those slides, but it was taking too much of time. That's why I just finally deleted all those slides. So I have my own way of tackling the lateral wall issues. So I thought I should share. I'll just first search where it is before. No, I didn't get where. Bhubaneswar, 10 commandments. How to get good results with IT fracture? No, not Boscon. Yeah. So, unfortunately, what is happening is the newer nails, whatever is available in the market, they cannot do the job, whatever I am talking. It is only possible with some of the nails which are available. Share the screen. Okay. Can you see the screen?
Yes, sir. Sure, we are.
See, this is a comminuted lateral wall. So this can be tackled by many ways. What Dr. Puneet was asking was trochanteric buttress plate, which is available in the market. Dr. Sunil Kulkarni and Sushruth Babulkar have wiring technique. I have my own way of tackling the lateral wall. This is Dr. Naveen's Takkar, where he uses a plate and through the plate he passes the neck screw. This is Dr. Ganjale of Sholapur, where he uses a plate to support the lateral wall and again he passes the screw through the plate. So basically, if you see, the head of the neck screw is being supported with a plate. This is Dr. Sunil Kulkarni, Sushruth Babulkar technique of wiring. So I'll just go to the one which I wanted to share. I use very rarely a trochanteric buttress plate. I can count on my fingers at present the number of cases I have done. So here you can see a badly comminuted lateral wall. I've used the nail. Against the nail, you can see. Can you see, Dr. Govind? You can see that against the nail, the screw head is touching. This is after 4.5 years. See, basically the screw head requires the support of the nail if the lateral wall is missing. So that has to be judiciously done. This was a demonstration surgery. I did it at Sancheti Hospital. You can see there is lateral wall broken. The medial wall was also broken with a huge piece. What I did in this case, because to compensate the medial broken lesser trochanter, I got extra valgus. You can see the neck screws touching the nail. So this is what I did. And this is just 1 month, 4 weeks down the line, you can see new bone has formed already. This patient was already 15 days old. So at 1.5 months time, 1 month after the surgery, you can see beautifully the bone has formed. So this is what I do. I feel that screw requires the support of the lateral wall. If the screw head is not having support, it will move like this. So it will move like this. So to prevent that, once it keeps on moving like this, what happens proximally? It loses the purchase. And once it loses the purchase, the screw walks out in osteoporotic bone. That is one of the reasons why 30% of the neck screws for transcervical fractures fixed with only CC screw fail. That is one of the reasons why we start using nowadays fully threaded cancellous to prevent the collapse. We don't want the collapse to happen. That is the reason why we use fully threaded cancellous screw. That is the reason why we use Powell screw nowadays. So this is a Powell screw which is passed at 90 degrees to prevent collapse happening. So we don't want unwanted collapse to happen. Here another badly comminuted lateral wall. Again you can see the screw head touching against the nail. This is very old X-ray where I have not tightened it fully. That's why it has backed out slightly. But you can see it has healed completely without any problem. This old man, just now I showed, 85-year-old patient, lateral wall was broken. It was so soft. My screws are touching the nail and the patient is walking comfortably without any problem. At 3 months, see, such a osteoporotic bone with a good subchondral hold, the screw never walks out. So you have to do proper surgery. Another case, again a demonstration case, I did it at Ganga Hospital in Coimbatore, badly comminuted fracture where I have used the screw heads against the lateral wall and the screw were long. That's why I couldn't compress it further because it was a sterile packet I had opened. So I didn't want to change it. That's why it has come out slightly back. This case I already just now shown where you can see that the screw is touching the nail against the lat, and at 4.5 years, you can see it's all remaining there only. Unfortunately, the original Synthus also not having a head. And I can boldly say today that this design of PFN, what done in India, is done by me, and it has not changed over the years. And here, against the nail, I can use my head of the screw, and it can compensate for the missing lateral wall. Unfortunately, none of the newer screw, you can see ZNN type of nail, PFN A2, Trigen nail, again ZNN, Halifax nail, none of these nails have got head. So that is the problem. If you are using a single screw head to compress the fracture, you should have something counter support at the head, which is missing. So that could be the one which I can say that this is how I tackle, because I have done so many cases. I shown only 5-6 cases where I had all the full follow-up till the union. But regularly I use this technique, and I'm very, very happy getting a good support. See, PFN A2, you compress 7 millimeter. Dr. Govind, anywhere in the literature written that the fracture requires only 7 millimeter compression? Why yeah, the fracture requires 10 millimeter, 13 millimeter. If you are using a lax screw, you can compress till you are satisfied. Unfortunately, that is not possible. If you are using a ZNN type of nail, there is no head to retain the compression you achieved. They say that you achieve the compression and put that screw from the top and tighten it, it will retain. It's not possible because the lateral side, the nail is medial, the lateral fragment keeps moving. So there is no compression which is retained there. Even the Trigen type of nail, you can put the screw, second screw at the 0 position, 15 millimeter or 10 millimeter. So if you keep at 0 position, there is no compression happening. If you keep at 10 millimeter compresses. If you keep at 15, it compresses 15 millimeter. Who is that person who has decided that this fracture requires 15 millimeter? So I feel that PFN with 2 screw system with lax screw with a head is the best implant available in the world. Unfortunately, my friend Govind cannot have, because they are not available in UK, they are not available in England, they are not available in America. It's only available in India, friends. You have to do the study. I wish people like Hemanshu, Kochhar or Singhal, they can do in their institution, study on this nail and produce paper, because what the world looks is paper. So we are not producing enough number of paper, unfortunately, due to technical issues. Why? I will also tell. Friends, Dr. Haldar came out with the Haldar snail. Then the Smith and Nephew took over the charge of the Haldar snail. They are selling Haldar snail left and right in China and Japan. They won a court case against Synthus in US court in 2006. So the patent of PFN is now not with Synthus in 2006 October, it's with Smith and Nephew. Smith and Nephew have got Trigen nail. They have got Trigen nail, they have got Gamma nail. When they have got 2 nails, why they will compete with their own Synthus 2 screw system in the market? Are you with me? That's why they are not manufacturing, they are not selling PFN anywhere in the world. Hip market is huge, but they have got already good share. Trigen is selling hot cake. Gamma nail is selling hot cake in China and Japan. So if they bring out their own implant, they are competing with themselves only. So they don't want to compete with themselves. That is the reason why it is not available. Unfortunately, in India, we don't have that much strict patent laws. We can copy anybody and we can sell. And Indian companies are doing it. And we are the only people who can write article about 2 screw system, because nowhere in the world PFN with 2 screw system with the next screw having head is available anywhere in the world.
Sir, which companies are having it with the head?
Almost all Indian companies have got the head.
All.
Because basically, see, when I designed it in 1999, we were not having special screwdrivers to hold it so that if the screw is 8 millimeter, the screwdriver also fits like that. So we made a head so that a screwdriver will fit into the screw with a head, because we were knowing only that technology. So that was unintentionally I designed at that time. But now I know the importance of that head, which I unintentionally designed in 1999.
Okay.
Sir, one last question is that what are your indication for trochanteric femoral nail, sir?
Any fracture. See, basically what happens is, I have my own technique of keyhole DHS, which I showed a slide. In spite of that, in the last 20 years, I might have done less than 20 cases of keyhole DHS. The only indication for me for keyhole DHS is undisplaced crack or incomplete fracture. Any other fracture, I would like to put a nail. Just now I showed a case. Yesterday I did the case. It was a plain intertrochanteric fracture, but when I saw it on the orthopedic table, there was a lateral wall fracture also. So there is enough literature saying that a stable fracture becomes unstable in 30 to 40% of your cases, either during surgery or in the immediate postoperative period, due to transportation of the patient. For stable fracture, DHS is the treatment of choice. But what happens on table? You find it is unstable. The fracture of the lateral wall happens when you're doing the reaming. What you can do? Unstable fracture DHS is not the treatment of choice. Then you have to shift over to PFN. But if you have kept PFN only, whether it is stable or unstable fracture, treatment remains the same. You need not have to shift your plan. You need not have to go to plan B if you are planning only for PFN. That's one. Second thing is, always learn the technique on a simple fracture, simple IT fracture, the technique of PFN. Once you know, once you do the graduation with simple fractures, then you go for post-graduation with unstable fractures, complicated fractures. Like the one Dr. Puneet just now showed, a subtrochanteric fracture. Once you start doing it for a simple fracture, you learn the technique properly, then you can migrate to more complicated cases. So this is what my advocate is. So for me, whether it is fracture, intertrochanteric simple fracture or a complicated fracture, PFN is a treatment of choice.
I think we should stop here now.
Yeah, fine.
Yeah, on behalf of Uttarakhand Orthopaedic Association, I would like to thanks to Dr. B.Shivashankar sir, our president, Dr. Govind Sethi sir, our moderator, Dr. Hemanshu Kochhar sir, Dr. Neeraj Bijlani sir, Dr. Singhal sir, and a special thanks to Dr. Ashok Suresh sir for organizing such a wonderful event. Thank you, sir. Good night, sir.
Thank you.
Thank you, Dr. Shankar. Lot to learn from your knowledge. Thank you very much.
Thank you. Neeraj? No, who is the host now? They have to stop sharing.
No, I am the host.
Ashok, you can stop live streaming.
No.
Beside live. No, beside live, there is view live stream on custom. There you go and stop it.
No, that will be done by Neeraj only.
You can do that. Then we can chit chat.
Okay, where to go?
Left side top, there is live button. Next to that, there is custom live streaming with arrow. Then stop live streaming you can do. Make the host, I will do that then, otherwise.